No, where did you go? Oh, that's where you went. Okay, can you guys see my main slide? Okay, I see head shakes. Great. Okay, thank you so much for your time this afternoon. So I'm going to be reviewing the therapeutic modalities, theories, and approaches that we use with our SUD population. And I'm going to highlight a few specific ones. I've given a similar presentation before. I'll probably give a similar one in the future. And my goal is each time, similar to the ethics didactics I give in ethics, in ECHO, try to highlight a few different ones each time we talk. Just a reminder, if you've sat in lectures with me before, you know I use my animals to help demonstrate the concepts I'm going to talk about. So here we have Waddles, who is reluctantly taking part in a photo session. This was a tough one since it was so hot last week. They were not down for this, but they went along with it anyways. So before I get further into these slides, could anybody give me a crystal clear answer on the difference between counseling modalities, counseling theories, and counseling theory approaches? Anybody going once? Going twice? Good, because I can't either. So it gets confusing, right? So sometimes a theory is just a theory. Sometimes a theory is also an actual model of therapy, like CBT. And then sometimes it's really an approach is just a specific intervention, like contingency management or motivational interviewing. So it's confusing. So bear with me while I'm going to touch on all of these. For some of them, the difference is going to be clear, and for some, you're going to see some multiple shared titles. So let's first talk about therapeutic modalities. So for us in the therapy field, we see firsthand the importance of the work that we do and the effect that it has on our patients' long-term recovery. So for other medical diseases or disorders, you know, sometimes the treatment's needed. It's just medication alone is what they need. But for our patients with addiction, really adding that therapy to the treatment plan can be a game changer. And so in therapy, the word modality refers to that method of treatment. And so the most common therapeutic modalities are individual therapy, group therapy, and couples or family therapy. For individual therapy, that's really the ideal modality for patients that have other co-occurring disorders and or a history of experiencing trauma, which we know applies to the majority of our patients. In the case that Hunter just gave, you know, that having that couple that there's a lot of times in their recovery treatment that's connected to each other, having that individual space to be able to process things is really key. For group therapy, that's the main modality recommended for patients with an addiction. And for those of you currently running group therapy sessions or observing group therapy sessions, you probably know why, right? That support and accountability that they get from their peers in that space can be incredibly influential. And then also listed here is couples or family therapy. So we know that the addiction doesn't just involve the individual, it also involves the other people in their lives. So if we have the opportunity to bring other family members in and it's safe for them to be there because they're in a place where they can be of help, we can really potentially affect change for that patient on a wider level. So ultimately, our task in therapy is to establish a trusting relationship with the patient. And when we do that, we're able to then help them address the underlying trauma that's occurred for so many of them, or other co-occurring mental health disorders. We can teach them about the disease of addiction. We can teach them what recovery looks like. We can help them develop that relapse prevention plan, and then assist them in developing sober support. So we talked about counseling modalities. Let's talk about our theoretical approach. My goats are here to help me with that. So the counseling theories that we use they sort of function as models of understanding of the client's narrative, and then what those identified problems are, and more specifically, what the patients are identifying as problems. So this helps us then determine the interventions most likely to develop or to deliver positive outcomes based on the client's needs and circumstances. While a set theory can really help us provide that framework for our counseling, we also want to be able to blend different approaches and techniques when they fit well together, and we'll talk about that in a little bit. And then here's a list of common counseling theories, specifically theories that are used a lot in the addiction field. I'm not going to review them all here, but take a look. And then tell me in the chat box if there's a theory that you use frequently that you think should be on this list. This list is not exhaustive. It's really just includes a lot of the main ones that I hear most frequently from folks that they use. But if there's anything on this list that you think I should add, please tell me, and I want to do that. I do want to remind us, and I'm reminding myself in that process, that these theories can't be these rigid boxes that we hold ourselves and our patients in. So for most of these theories, they were founded a long time ago and in a different world than we live in today. And so when we're looking at theories, we've got to recognize where cultural differences are playing a role here. I'm going to review Maslow's hierarchy of needs in a little bit, and that's an example of a theory that doesn't necessarily recognize cultural differences. Let me take a look in the chat box. I'm not seeing from anybody that there should be other ones I list there. Okay, so we talked about modalities. We discussed theory and how that becomes our framework. And so now let's talk about approaches. So as medical professionals, our job is really to provide the best patient care while also, maintaining professionalism and compassion. And one of the ways that we can do that is by facilitating evidence-based therapy. And so here's a list of the most common therapy approaches that we hear used in the addiction field. So cognitive behavioral therapy and dialectical behavior therapy are the most common ones. The last time I gave this, I didn't have ACT on there. I don't know if Dr. Husted is on here, but he was the one that said, you know what, you should really have ACT on that list. And I should. I'm so glad that he mentioned that. So we've got ACT added on here. We have internal family systems therapy, EMDR therapy, and brief therapy. And brief therapy is going to be one that I'm actually going to highlight in a little bit. Again, if there's main ones that you think should be added to this list, please holler at me. And then here's some specific theories or broader interventions or approaches. So for example, we've got motivational interviewing on here. Now, motivational interviewing isn't an actual therapy. It's more a style or approach that we use with patients, and that can be easily blended into the therapy framework we're using. So relapse prevention is something that could be used at any of those different theories on the last page. Mindfulness practices can be built in there. We're using contingency management. Some of you are using contingency management in COAT, maybe in the greater context of a CBT group. And then we have 12-step facilitation therapy on there. So we've reviewed the general definitions of modalities, theories, and approaches. As I mentioned the last time I gave this similar didactic, I specifically highlighted CBT, DBT, and motivational interviewing. So today I'm going to specifically highlight Maslow's hierarchy of needs and brief therapy. So chances are pretty high that you've heard of the hierarchy of needs, whether you've taken a psychology class or not. So Abraham Maslow suggested that the needs on the pyramid's base, so we've got food, water, sleep included there, that those have to be met before people can move on to a higher level to meet those higher needs. So an interesting fact to note is that Maslow himself, he never actually presented this theory in this famous pyramid model, which we're familiar with. He did not view that these needs as levels or stages you reach before you have to meet that before you move on to the next. He really believed that people move within the hierarchy and that we are often driven by multiple needs simultaneously. So you can have some needs met, let's say, in your personal life, but not needs met in your professional life. So this can be a great framework to consider when working with a client. So if I have a client who is experiencing homelessness, who was living outside last week and this week during this horrendous heat wave, am I really best helping them if I'm focusing on, in our therapy, if I'm helping focus them on adding to their creativity or developing their spontaneity skills that are at the top of that level? Probably not, right? They probably really are going to be best served if I'm working on their physiological needs, their safety and security. Where are they sleeping tonight? Do they have access to food and water? So while this framework can be useful, again, we want to make sure to not be rigid with it. So some researchers have noted that Maslow's theory doesn't account for cultural differences. So Maslow's observations were primarily based on people in his own social and cultural group, so white, Western, and male. So as providers, we need to make sure that we're accounting for the different motivations and needs of people in different cultures. And we do that as therapists by building that rapport with the patient, getting to know their history, and what their personal and cultural identity is, and allowing them to define what their own needs are. I'm going to pause there and see. For some reason, I can't. Sometimes I lose the chat box. Kelly, can you tell me if there's any questions in the chat box?
I am not showing any.
Great, thank you so much. So the other approach I'm going to highlight here is brief therapy, which is also known as solution-focused therapy or solution-focused brief therapy. So the philosophy of brief therapy is that we don't know how much time we have with a patient, so let's make every minute count. And so the idea is that the intervention is prompt and early, that the potential that very soon after meeting a patient that we're able to provide them this kind of support and guidance. The idea as therapists is that we're going to be active and directive with them because we recognize that we may not have a lot of time with them. The goals are specific and time limited. How can we help them right now in this moment meet goals that are potentially smaller and obtainable? The therapy focuses on the here and now. Again, we want to focus on maybe limited goals, smaller goals, or fewer goals. And a way to do that, focusing on goals that are going to potentially help them reduce symptoms and enhance coping. And then our therapists, our focus on goals, assessment, we want to do what we can to get necessary information with a flexible intervention approach. So, for example, Joshua is on the call here today. He and I met with a patient this morning to do a full intake. This was a patient who already had some consistent time in sobriety. They were well over a year in sobriety. They had been in treatment before. They kind of knew what to expect in the intake. They were at a place in their recovery that they were really able to stay present with us. So we were able to have a pretty long conversation and gather a lot of information from them. That's not always the case, right? Sometimes folks are showing up for an intake. They are in crisis mode. They're not in a safe place to live. There's not a safe person. There's a dangerous person out in the car waiting for them. We don't have an opportunity to get a full-on assessment with them. So it's possible that we're going to be gathering just as much information from them as possible to then be able to provide some help with them in that moment. So one technique used in the brief therapy context is called the FRAMES approach. And so FRAMES stands for feedback, responsibility, advice, menu, empathy, and self-efficacy. So for that feedback level, what we're doing is providing them therapeutic feedback that's going to potentially help them develop awareness of how their substance use has affected them, potentially in a negative way. Our approach as the counselor or therapist, we want to encourage the client to take responsibility for their choice to use or not use, but from a not shaming place, which sometimes that's a hard balance to find. So we really want to make sure that we're bringing compassion in that conversation with them. For advice, if you notice, if is capitalized. So if the client gives permission, counselors can extend advice in a non-judgmental manner, but we really want to make sure from the patient that they're in a place where they're ready to accept that, as opposed to us just giving unsolicited advice. The menu level is about us providing with them a menu of decision options. So potentially from an intakes perspective, we're going to be offering them a menu of treatment options in terms of treatment levels that they could potentially participate in. Empathy is all about, again, establishing that collaborative relationship with the patient from a compassionate place and a non-judgment place. And self-efficacy is key here in terms of helping the client to see themselves as being able to make these decisions, and therefore they have a hand at getting to change their lives if they want. So if we had to boil it down to one thing, what's the most important aspect that we want to consider with each of these modalities that we use, each theory that we conceptualize the case with, and each therapeutic approach we use? From the patient's perspective, the most important thing is that connection that we develop with our patients. So the research has repeatedly found that the quality of this relationship, that therapeutic alliance, as you call it, is the strongest predictor of whether or not the therapy is successful. So the magnitude of this relation appears to be independent of whatever type of therapy that we're using, whatever type of approach we're using. And so large studies have been conducted looking at individual therapy, couples and family therapy, using a variety of different assessment methods to measure the quality of that relationship. Those studies also looked at diverse patient groups. So they looked at children and adults, folks at residential setting, folks in outpatient setting, treated for all kinds of mental health needs. And all of the studies show the importance of that therapeutic relationship on the treatment outcome. Now, interestingly, patients and therapists don't always agree on the quality of their relationship. For any of the providers on here, really, I think anybody on the treatment team, I don't know if you've ever had that experience where you didn't think you were being really helpful to a patient, or you didn't necessarily think that therapeutic alliance was strong, but then the patient gave the feedback and they felt very moved by this last session that you had or this thing that you shared. So it's not always our perspective. Actually, the patient's perspective, their perception of the quality of the relationship is the strongest predictor of treatment success. And so the patient's ratings of their relationship with the therapist, even very early in treatment, after the first session or two, that can potentially predict their improvement over the course of treatment. And then we mentioned that's, the most important aspect for the patient, that therapeutic alliance. Let's talk about what's most important in the approach for the therapist, and that's for us to feel validated and supported. So it's imperative, us as providers, as therapists, counselors, that we're participating in regular supervision to manage our own thoughts and emotions that are going to pop up when we're helping a very challenging population. In addition to supervision, I think regular consultation with our colleagues, just regular talking with our treatment team, being able to have a connection with each other, that's going to help us problem solve in the moment, and then hopefully implement effective treatment in those challenging situations. I'll call out Tony as an example. So I share a treatment team with Tony and Travis Cottrell and Caitlin Cool, I'm not sure if they're on here. And we run our highest level of care group, our ICOTE. And so these are patients often with complex needs. They've come to us for a variety of different complex reasons. And I am frequently reaching out to Tony and Caitlin and Travis going, oh, I think this is what I want to do. How does it sound to you all? How do you think about this approach? We're often having to kind of fine tune or pivot our approach in the moment. And I'm able to do that because I feel supported by them. So we want to make sure that we're providing that space for each other to also honor the grief that we experience in working with this population. If I asked for a show of hands on these Zoom calls, how many of you have lost a patient within the last year? I bet I would see a lot of hands or Zoom yellow hands. And so we really need to give each other that time and space to express that grief and support that grief. And then finally, my favorite type of support I get from my colleagues is the art of humor. I find that most supportive. I had to restrain myself from including 47 memes about therapy in this presentation because there's a ton of great ones on the internet. Therapists are really made fun of them, but sadly, a lot of them are pretty accurate. So I think that's the end of my slide. Again, I just always appreciate each one of you on here for what you do for this population, what you do for our addiction community and our just larger West Virginia community. So thanks for all you do. And here are my references and ending my slides.
Thank you, Katie, for sharing all that with everyone. That was very good.
Thank you. I'm looking at the chat box to make sure. Did I miss any theories that you think should be on that list? Or therapies that should be on that list? Okay, good.
All right, well, I thank you so much for sharing that, and that was very good. At least I enjoyed it. If nobody has any questions, we'll go ahead and wrap up for today. Our next session is going to be on July 8th with Laura Landers. She's going to be talking about treatment of pregnant women in SUD. So I hope everyone has a great rest of your day, and I'll see you in 2 weeks. Thank you.
Thank you.